T, I need to come to your house, I think tomorrow to get that book. Hello and good evening. Thank you for joining us this evening. My name is Camilla, and I'm the Black Maternal Health Coordinator for Black Lives Matter in New Hampshire. And this week is Black Maternal Health Week. I'm so excited to have you guys all here and our powerhouse of a lineup of women this evening. I know that we have just an hour, but we have a lot of stuff to cover and a lot of great topics. So I'm just going to jump in and let the panelists introduce themselves. So we'll start with Tiffany and then I'll go across my board.
Sure. Hi, everyone. Thank you for having me tonight. It's an honor. My name's Tiffany Vassell. I am a labor and delivery nurse by trade. I'm a Black maternal health advocate. I'm the VP of Bay State Birth Coalition, which is a consumer-led advocacy group that advocates for midwifery care, access to midwifery care and doulas. I'm a mom of two. I am currently the director of Healthy Baby, Healthy Child, which is the legacy maternal child health program at the Boston Public Health Commission. And I'm also an author. I've written a book called Preparation for Hospital Birth, which helps people get ready for delivery in a hospital. Thank you for having me.
Thank you for being here. Kyra?
I am Kyra Betts. I am a doula, a mother. I am a policy and advocacy manager for a nonprofit. And then I'm also the, what did we decide to call it today? I designed the training for DAS to doulas. And I'm also the lead facilitator there and the VP at the Doula Lab.
Thank you for coming. Khadijah?
Hi, so I'm Khadijah Mower. I'm currently a stay-at-home mom. I have two small children, Iris and Isabella. I am also a storyteller, a little bit of a backstory. I share my personal lived experience with losing my son in 2022 to a stillborn birth. So I usually come on these platforms and share my experience, strength, and hope with everybody in navigating that challenging situation. But I'm really excited to be a part of this conversation today.
Khadijah spoke at our maternal health conference and there was not a dry eye in the room. So amazing. Tanya? Denise? Oh,
Hello,
I think her
everyone.
screen, I think you guys, are you guys all? Oh no.
Hello. Can y'all not hear me?
Yes, we can hear you. Sorry.
Okay, great.
Glitched for me.
You seemed alarmed.
Yeah.
So my name is Tanya Denise Fields. I am the executive director and founder of a New York-based organization called Black Feminist Project. I am also the fierce mama bear of 6 humans, ages 22, 21, 15, 16, 10, and 9.
Tanya also was our keynote speaker this past year at our Black Excellence Gala. Completely slayed it, just killed it. We're gonna have a tough time finding somebody else this year. Okay, and then is it Camila or Camilla?
Hi, it's Camila.
Okay.
Sorry, I just got off of work, but thank you for inviting me. I'm Camila. I am an OBGYN doctor. I'm in the final year of training. I have 3 months left. And I'm in Chicago actually. And so I'm really excited to be here. Thanks for having me.
Thanks for coming. Okay, so we're gonna jump right in. Please, well, we have questions, but please make it as organic and wherever the conversation leads you, just let it go. Okay, so the first question is to everyone. How do hospitals and healthcare institutions benefit from the continued harm of Black birthing bodies, and who's profiting?
I'll start. I've been thinking a lot about what is the benefit of these systems not changing, right? Because ultimately they get a bad reputation. Sometimes they get sued, and so then they lose funds due to malpractice. But I think it is a benefit in the same way that police departments still benefit from discrimination against Black and brown bodies, right? In that it keeps the system afloat, right? That so much of the system is designed around harm, that it would almost be too much for them to change. It would require a lot of money and a lot of time for them to change. So while there's no, I would say, monetary benefit, there's still a societal benefit from the lens of like white supremacy of, well, who actually cares? We don't have to change. So that's what I would say. I'm not sure what the other panelists think.
I can go. So we have to remember that hospitals, healthcare is a capitalistic system. Yes, you come to the hospital to receive care, but you're also taking up a room. The sooner you deliver, the sooner we can get a new patient in. The system does benefit from and profit off of Black pain and poor outcomes and Black bodies. We know that it's direct, it's insidious. Institutions receive higher reimbursement rates for complex birth. And that's just the fact of the matter. Complex births and complex interventions. So C-sections, NICU stays, those types of things, it's a lot of money, so and those things are things we know that Black women disproportionately experience, right? So our bodies are being policed, uh they're being used instead of nurtured. And yeah, it's unfortunate, but yes, the hospital is a capitalistic system and it does all come down to money, unfortunately, and reimbursements, the highest reimbursement.
I would also like to just jump in too and let us just acknowledge that this system itself was built off of the continued experimentation of Black female bodies, right? Henrietta Lacks cells are still in rotation to this very day. It was done without her consent. Fannie Lou Hamer went in and got what they called a Mississippi appendectomy, which is where they will routinely just take a woman's womb without her consent. She thinks she's going in for a routine treatment, and it comes out without a womb. And those wombs were being experimented on. They were being used to make medications for pharmaceutical companies who were benefiting very deeply from that. So we have to understand that the medical system is a reflection of dominant oppressive society, and the dominant society in America has always been the continued harm, experimentation, and commodification of Black bodies.
And Tanya Denise, thank you for mentioning those women. We also cannot forget the mothers of gynecology, Betsy, Lucian, and Arca, who we can't even call them women. They were adolescent girls who Dr. Sims experimented on their bodies without any anesthesia and then went back and did the same procedures on white women with anesthesia. So we also can't forget those young girls and many others that we don't even know their names, whose bodies were used to further gynecology and obstetrics.
I'd like to piggyback off of Tiffany a little bit. For me, I think that hospitals and healthcare institutions benefit both financially and structurally from the continued harm of Black birthing people, from unnecessary interventions, like Tiffany mentioned, C-sections often performed without informed consent, to the undertreatment of pain. These systems are usually set up to prioritize efficiency, control, and profit over holistic care. And when we mention insurance companies, pharmaceutical corporations, and hospital administrators, they all benefit from the commodification of Black pain and labor.
Okay, amazing. We've only been in for a couple of minutes and you guys are dropping gems. It's amazing. Okay, so the follow-up question is to Camila. What are the most harmful myths about Black women's bodies that still persist in medicine, and how do we begin to dismantle that?
Yeah, I was actually just really thinking about these questions before hopping on and talking to one of my co-residents actually about the questions that I got. And we were still, I think Black pain is something that you always hear about, that Black people don't feel enough pain. And actually, there's a lot of different stereotypes when it comes to different groups coming into the OBER or coming into labor. And I have to constantly check some staff members when I realize that there's patients that are going through significant pain and either are blatantly ignored, not given their PRNs, not taken seriously, or seen as being dramatic, seen as being a very emotional, that there's other things that are triggering their pain other than the actual physicality and the physiological changes that the patient is going through. And if you don't address the pain, pain is a vital sign. That's sometimes what we refer to it as, because it's an indication that something is wrong. Even when somebody has a medical indication to have that pain, it's still written off as something else. It's written off as, well, they've had, like it's, if you're on your fourth C-section, you're coming in with pelvic pain. It's like, well, what are we going to do about that? Like, you've had these four C-sections forever. Why not? Why are you coming into the ER now? Like, what are you looking for? What specific thing, an answer do you want? Because we cannot give you a solution. So it's just written off as a chronic pelvic pain patient, which is seen as burdensome. It's seen as something that is passed off to the next person because they don't want to deal with it, when we are the cause for the fourth C-section and the third and the second and the first. And so I think it's just lumped into, a bigger or a cause for something else, when really the way I like to see it, and the way that some of the best doctors that I train under see it, is if we opened their body, if we did any surgery, that patient is ours for the rest of our life. And because I was taught that from a very early stage start, I know that even if a patient comes in with chronic problems, that ultimately it's my point to address and not just write it off as, well, there's nothing I can do for you, because it's really distressing and it becomes a very long-term painful process for people to completely write you off, specifically from a pain perspective. People can't think straight when they're in pain. People go a little nuts when they're in pain because they can't think of anything else. And it's unfortunate. I see some higher ups, some specialists really write it off to the point where you can't even bring it back up. It gets really tough to try to advocate for some of these patients, because they'll basically just discharge them and say there's nothing we can do for them, and they need to go find somewhere else to get their care. And so I think, if I could speak on one thing, pain has been a very, it's not hidden either. I think we hear about it all the time. So I'm not going to say it's hidden, but it's something that continues to come up, that's still blatantly ignored.
Mhm.
Yeah, and I think we know that, or historically we know that providers feel like we have a higher pain threshold, and maybe that could be true to some extent, through adaptation, but it still doesn't pass for all the things. Um, Next question is, and this is for everyone, can trauma-informed care exist in a system built on anti-Blackness? And if not, what does care truly look like for us?
So no, not in the system's current form. It's like the system was built on anti-Blackness, right? So it's like just sprinkling trauma-informed care language like over harmful practices, and like saying, oh, we did a thing, right? We healed some folks. I think right now how it's currently being used, it's like such a buzzword and it drives me crazy. And I'm like, well, what does that mean? And it's like, when you truly care for someone that's birthing, like, it looks like listening to that person, providing a safe space, allowing that person to have autonomy, um, letting that person trust their body as it goes through the process, right? And believing the person, as Dr. Evans mentioned, when they say they feel pain, and respecting whatever choices they may make in their laboring process, and honoring the whole person and their identity. They're more than just a chart. I feel like a lot of healthcare providers do treat people like, it's a patient, got to get through it, move on to the next, and it has to stop. And also, it means receiving care from people that look like you. Like, let's be for real, we need more Black and brown people in healthcare spaces, that speak the language that people do and share the same cultures.
I think for me, Tiffany, I agree with you. I'm over trauma informed. I'm tired of hearing about it. the whole system itself, you're talking about trauma-informed care when the system itself is actually traumatic and it is intentionally built to be so. I would like for us to shift towards healing care, right? I don't want anybody else talking to Black folks about trauma. We got that down, okay? We can write books, theses, all kinds of stuff, right? I want for us to think about not only talking about healing informed care, but also building systems that reflect the actual authentic and genuine desire to actually heal people and thinking about what that looks like holistically, right? What does it mean to, and then, right, so when we're talking about healing people's bodies, we also understand that stress, right, lives in our body on a cellular level. This is why when we're talking about maternal mortality rates, we are seeing higher rates of Black maternal death across all socioeconomic um, stratifications, right? So it doesn't matter if you're a rich Black woman or a poor Black woman, your likelihood of dying in childbirth does not decrease because having access to so-called better medical care doesn't exist because we are actually thinking about the ways in which we are looking at generational trauma and racism living in people's bodies on a cellular level. There is scientific data to support that. This is not something that we just made up, right? So I think we have to just even reinvestigate why we're using some of the terms that we're using and what it means for us to completely shift that perspective.
I'll also say, I used to, before becoming a doula, I became a doula because I used to do training. I was a corporate trainer for a very long time, specifically in the hospital systems. And so I used to do the trainings that people come out of and say, oh, yeah, we're trauma informed now. We come from a trauma informed lens. You cannot train racism. Like, you can't out train that. You can't there's no training I can give someone to rewire the way their brain sees black bodies. I just can't, right? And so when we're talking about trauma informed care and we're talking about that in the scope of this system, it doesn't matter, right? We still allow J. Marion Sims to be considered the father of gynecology. There has to be like an upheaval of a system in order for there to be true care, right? Like Tanya was saying, like healing care. Because otherwise, if we're allowing that to still happen, if we're having medical students as recently as 2018, 2019, still believing that Black people experience pain differently, it doesn't matter what training happens, what label we slap on it. None of those things matter because the system itself has not had the upheaval that it needs.
I can jump into. I think trauma-informed care becomes a catchphrase when it's used within a system that is inherently traumatizing to people. Um, you can't be trauma-informed and continue to expose people to structural violence. It's a system that's built on anti-Blackness. True trauma-informed care would require a dismantling of that system altogether. For us, I think that care looks like recognition, being seen and believed. It looks like cultural grounded, consent-based, relationship-centered support. It means that we have doulas who speak our languages, midwives who honor our traditions, and providers who center our autonomy. It's not a checklist. It's about trust and respect.
So Tiffany,
Yeah, I would.
oh,
Oh,
sorry, go
sorry, go
ahead.
ahead.
No, you go
No,
ahead.
no. Oh, okay. I would say that I I think in the hospital, there's still a real need for trauma-informed care because people inevitably are going to have complicated pregnancies that deliver in the hospital. And I think, unfortunately, when you are dealing with this reality, and specifically probably the next 10 or 15 years before things start to change, it's any trauma-informed care training that I got really was not as applicable as me just being a Black woman, seeing another Black woman in distress and being there for her in the ways that I know how, in the ERs, taking the time. I have a very specific patient that I am thinking of as I'm speaking about this, for a patient coming in with her fourth C-section, which is actually funny how I keep on talking about all these C-sections. And her water had broke, and she was in so much distress just because of the thought of her not being able to make it off the table. That was the biggest hurdle. That was the biggest jump, that she just felt like, and she had had C-sections before that were fine, that were able to be, like everything went fine, but her mind was so caught up on her morbidity and mortality. And I couldn't lie to her and say, hey, like, everything's going to be perfect. We know this is a risky surgery. We know that this is what happens with certain things like that. And I'm not going to lie, from 9 a.m. when she got there till after my shift ended at 6 p.m., I stayed with her every single second of that day. I missed lunch. I missed everything because she was like, you're calming me down, but it's going to take some time for me to get there. And throughout the day, anesthesiologists were coming in, our attendings were coming in, everyone was being very nice. But I think the specific difference between me taking care of her and all these other doctors that were actually very nice and kind of tapping her in her face was when you walk out the room, when you go and you're talking to your colleagues and you hear the conversations that are being had of, oh my God, like this is getting absolutely ridiculous. And like those thoughts and never crossed my mind, because I was more focused on making sure this patient felt comfortable to sit on that table to do the surgery that was necessary for this baby to come out. And to the point where actually we got like the top anesthesiologist on board, me, I stayed after work to do the surgery for her. It ended up being a great, fine surgery. But for, I could only imagine if she went to another hospital or someone that was not me taking care of her, they would have probably called psych. They probably would have gotten some type of PRN necessary to put her to sleep, because it wasn't about 8 or 9 hours had gone by before the indication of the C-section actually occurred. And so it's those conversations, even if they're being nice to you in your face, I'm kind of behind the scenes and hearing the discussions, that are pretty harmful and pretty scary, the things that people are saying about like how dramatic this woman is being, which is not true. Like, this is a very important and scary surgery, and she has reasons to feel scared. And in order to get there, you have to work with them. And that's, to me, trauma from the medical system. It had nothing to do with anything else. And so I think in the hospital, we still have to find ways to make trauma-informed care actually applicable to the patient, even if that falls outside of like the standard of what that training allows, which is like, I don't even think any training would have allowed for that patient to stay pregnant for that long without someone advocating for her in the room. And I stayed with her. I did not leave her side, because I didn't know what was going to happen if somebody else would have assumed her care, as her primary provider. So I I think rhetorically it makes sense, but when you are seeing these patients coming in with their histories, we still have to find not just the language, but the reality that is needed to take care of patients that are absolutely traumatized by the medical experience, that still have to go forth with the procedure that they need to do.
I feel like what you're saying is essentially what all of us mean when we say you can't train it, you can do it. You can genuinely approach care from that perspective. But I think that's less about trauma-informed care as a construct and more about who you are as a provider and what's important to you and how you are able to see your patients as whole people and what they deserve and what they require, and being able to go above and beyond. And that is not what they learn in trauma-informed care. You are just a really good provider. You're an amazing provider to see it through, because too often 7 p.m. hits or 7 a.m. hits and the doctors are like, see you later, gotta go, I'll transfer you up to this person. And so I feel like, yes, everything you just said was trauma-informed care, but that was because of who you are. That's not the way that anybody would train
And
you.
I think that's
It's who
absolutely
you
why,
are.
like, the selection process has to pick the person that cares about the human, and not just because they have good hands or they know how to like get like the highest score on STEP, but it's like the people going into the field of obstetrics and gynecology actually have to care about the woman. And I think even talking to some of the higher ups that are hiring for these positions, I literally had a black man, black male OBGYN, tell me to my face that he will throw away an application if he sees anything about an applicant that really cares about providing care for women's health, which is insane because that's literally the whole definition of what an OBGYN is. And he said, like, that shouldn't be the focus. The focus should be on surgery. The focus should be on, can you give me a good 1 minute, like, speech on this, and can you get me down? Can you get this patient discharged? Are you efficient? And so he told me to my face, he would throw out all applications that humanized the people instead of actually the other way around. He really cared about statistics, numbers, hands, skills, letters of rec. And so that selection process goes far beyond like the only way to actually change trauma informed care, like you said, is not the training, it's the people that you're selecting to do not only the training, but the care. And that goes all the way back to who's being selected and who's actually being admitted to these programs.
Camilla, I think that you, Camilla or Camilla? How do you pronounce your
Camila.
name?
Camila. Yeah.
Camilla. I think that you make a really good point, and that's something that I've been thinking about a lot in my work. Even though I'm not necessarily in public health in the way that you or Tiffany might be in public health, but as someone who is forward facing, dealing specifically with non-men led families, and thinking about reproductive justice as an umbrella concept, right? Not just about access and to birth control or to abortions. I think that one of the things I've been thinking about in regards to what you're saying is like, how do we, as practitioners in our community, start thinking about how we can start to create pipelines, right? Like, how can we start to have this language be very accessible to people in our community? And for those of us who are interested, thinking specifically sort of at the high school level, ninth and 10th grade, really start having our young folks thinking about wanting to go into medicine, and particularly wanting to go into medicine around obstetrics. And also, not to discount, like, no shade to you, girl, midwives should be catching babies. And so I think that it is really important for us also to be thinking about the return of midwives and doulas and birthing centers into our space, because by trade, obstetricians are surgeons. They want to cut. Like, that's what they do. That's what they're trained for. And this idea that anybody delivers your baby, even that language is crazy, because I deliver my baby. You are assisting and helping to catch my baby. And so I think, uh, how do we create this to be something that we actually care about in our community? That's just as important as police brutality, as housing, as equitable education. And then how do we create pipelines for that to start seeing more of our young folks choosing this as a pathway, whether it be gynecology and obstetrics or whether it be as midwives?
Mhm.
Okay, Tiffany, follow-up question. As an RN, can you speak to the specific healthcare disparities Black mothers face in the system and how those disparities impact their experiences during pregnancy and childbirth?
Sure. So I think one of the primary issues that Black women face is that they're not being listened to. Again, you go into the hospital and it's a process, and a lot of people don't understand, like, once you enter the hospital doors, like, there are policies in place and the system just churns, and it's like you come in and you move right along with the system. So I think the biggest thing is not being listened to, not coming prepared. So it's very important that the provider throughout the prenatal experience explains like what's going to happen when they come in, what are some of the interventions, what are some of the risks, to help people be more educated about the process. Because again, people come in and then all of a sudden they're being offered interventions and you don't know. You're like, this is my provider, I trust them. And you get sucked in, and before you know it, you've gone from meso to Pitocin to Foley bowl. Now it just becomes, again, a mess. And then before you know it, you're in the OR because your experience is being rushed along. So again, listen to Black women when they're going through the process, and educating yourself about the interventions is a big thing, like knowing what can happen and knowing what each intervention is, so that you can have a conversation. A provider comes in and says, hey, we're going to start this. And you're like, no, actually, I don't want to start that. Can we try this instead? So I think those are some of the things.
Yeah. And Dr. Evans, how do you ensure that Black women's voices are truly heard and respected in clinical spaces? I know you talked a little bit about this.
Yeah, I listen. I'm all ears. I probably take too long. I get um, feedback about it that I take too long and that I talk to patients too much, but I am all ears so that I can get down to the bottom of it. Because truly, if you don't cut people off and you actually hear them out, you really can't get down to the bottom of certain things, even if you have a limited amount of time to address things in a way that is productive still. I think I have two instances of surgical examples of me actually listening to the patient. And because I'm the one that counseled them, because that's usually if you're in a teaching hospital, the residents are the one doing all of that, to advocate for them in the surgery, which sometimes doesn't happen. So I had one patient, this is not from an obstetric standpoint, but from a gynecology perspective, where she had a multifibroid uterus, which she had been trying to fix for many years. But first they're too small, then then she lost her job and she didn't have insurance. So it kind of developed into this huge fibroid uterus. She never had a pregnancy. That was what her goal was, to achieve pregnancy, but she didn't have a partner right then and there. And so we had to talk about all the different ways to achieve this fibroid removal. And one of the parts of the consent, which I actually, you're not taught this until you actually do one of these surgeries and you realize how bad and bloody it can get, depending on how big the fibroid uterus is at a certain point, these things can actually turn into a hysterectomy. I don't think people really realize that. They think they're going in for a fibroid, and it's not the first time that I've seen these things turn into the uterus is completely removed because of the amount of blood loss that happens. And so you have to ask specific questions like about when would you want us to stop removing the fibroids, because if not, it will turn ultimately into a hysterectomy. And I remember her looking me in the eyes and saying, do not remove my uterus under any circumstances. And I said, even to save your life? And she said, if it becomes to save my life and that's your only option, sure. Otherwise, do not remove my uterus. I want to have children, even though everybody was skeptical. She was older, she didn't have a partner. And so everybody's like, that isn't, there's no way she's going to get pregnant anyways. And so some people approach it with those thoughts in the back of their mind, right? And so I said, okay, I listened to you. I listened to it. And surgery happened about a month later. I was in the OR and we probably removed about 50% of her fibroids. But every time we tried to close her uterus back up, there was another fibroid. So you had to remove it. Then there was another fibroid. Like her uterus was literally filled to the brim with fibroids. There was no way to close it. And so at a certain point, the attending goes, open up the his tray. And I looked at the attending, and I really like this attending. And I told her, she does not want a hysterectomy. And she was like, well, there's nothing I can do. She's already lost so much blood. And it was true. It was getting to the point where she was going to need an ICU stay because of the amount of the blood that she was getting. And I was like, we haven't tried everything. Like, we just have not. And at that point, I was still kind of like in the middle of my training, but somebody had mentioned another stitch. And I was like, why don't we try this stitch? And I'm just calling it everything. I'm like, do this, I'm just trying my best because I'm the one that counseled her. I know exactly what she did not want. And this is not to save her life. This is just to kind of stop the surgery because we can't stop it. And so she goes, okay, fine. We're going to try one more thing. And if this does not work, open up the his tray. Luckily, the stitch worked. It was the one thing that held the glue together of this uterus together. And I said, get about 10 of those in there because we got a lot to sew and recover. And at the end of it, she fine. She kept her uterus. She was out of the ICU in about a day. She just needed to recover, like, hemodynamically. And it was fine. But if no one else was there to listen to this patient and get her needs, even though her risks are very low of getting pregnant at the age of 40, whatever, it was what she wanted. And that was the thing I listened to. And so I have and I will step in front of beds. I will step in front of attendings to another. So that was a gyne patient, another obstetric patient I had actually was only a month ago. And she was a new pregnancy, first baby, came in labor, really just did great. And then I got on shift at night. I was with an attending that is one of those cutters, right? He's a surgeon. That's what he says. Like, I'm a surgeon. Doesn't really do obstetrics. And so it was really weird to even see him on the floor out of L&D because he's usually in the gyno ward. And this is a Black woman with a beautiful Black family. She's making change, but then she gets to 6 centimeters. And of course, things start to happen with the fetal heart tracing. So I go in there and the heart rate going down. That's one of the indications for an emergency C-section. But I was like, she's 6 centimeters. Like, that means that she's making change. We know and we expect certain things to happen. Like, I feel like I love the category two tracing. I know how to manage it because I want people to have a vaginal delivery if it's safe for baby and mom. And he went in the room, not even after, like the Pitocin was still going. She hadn't even gotten a bolus. Like, and he was like, I don't like the tracing, let's go. I, I looked at him so crazy. I was like, no, like I literally was just like, that's not happening. And so I was like, how about we just turn off the Pitocin first? And so we turned off the Pitocin and I said to start the bolus and do the things to resuscitate the tracing. That is what we're trained in. And he just leaves. He kind of ignores me, comes back 10 minutes later. Oh, let's go. It's getting better. Still not perfect, but who, like, no one likes looking at these type of tracings, but I don't act on it until I feel like I've done everything I possibly could. And he starts to unlock the bed. He literally unlocks the bed and says, get her to the OR. I immediately relocked it because what I noticed was that the patient started throwing up. And we all know that people have been on labor and delivery. When you start throwing up, you're making change. You are going through a change. And she was really, really throwing up. So I was like, I think, and I just had it in the back of my mind. I was like, I think she's going to be complete. And so I finished. I was like, you keep on throwing up. Just do that. Like, keep on doing what you need to do as just a human being that is uncomfortable with throwing up and pregnant and is about to be delivering her baby. And I was like, let me just check her before we roll her back to the OR. She was 10 centimeters. So thank God, I was like, oh my gosh, you're 10 centimeters. We're going to start pushing. He still was like, I don't like the tracing. I don't like how it looks. She said, prime it. Let's go to the OR. And I was like, what indication do you have besides you don't know? You don't know if she knows how to push. So I asked her, I said, do you know how to push? And she goes, no. But she's a young girl. I was like, can I teach you? Like, can I teach you how to push? And can we try? Can we do this for like 10 or 15 minutes and kind of talk to her at that point about opera delivery just in case I needed to? This lady, I said, with all of her might, push this baby out. I did have to use an operated vacuum, but there's no tears. Baby stayed in the room, no NICU stay, no nothing. After 15 minutes of relocking the bed, arguing with this attending over and over again, because she came in a natural birth and she made change all the way to complete by herself. I mean, they did start the Pitocin around 6 centimeters. That was a decision before I got there. But she ended up having a beautiful vaginal birth with this Black family that came in the room. And they were just like, thank you so much for not pushing her into the OR when you didn't try everything you possibly could. And I really, from a resident perspective, I'm not really allowed to do anything else. And so I'm glad that I was able to push for that. And I felt really emboldened because this was a surgeon telling me I needed to do the surgery now as a senior resident. And so I just feel like it takes more than just listening. It's actually like putting yourself in between the person that is forcing decisions in you and having a provider being able to do that without and then knowing what they're looking at, knowing the actual like knowledge to be able to manage that instead of just being like, okay, you know best, you're a white man, let's go to the OR. That was not true. At that point, I knew that what's best for that patient, and he was not the expert at that time. And so I think I'm always, even if it is at risk for my job, I will do everything possible to get people to their goal, which is for that patient, it was a very vaginal delivery. For the gyne patient, it was to keep her uterus. And so I always try to get one thing and stick with it. So that's kind of like my two story times from both sides of being an OBGYN.
The power that is Black women providers. It's amazing. I stated before, so we are in New Hampshire, so it's a really white populated state. I have birthed all four of my children here. I've actually had four C-sections. The last one was completely traumatizing. But like I didn't know. I mean, I had my first son, I was just 21. I didn't know that I could advocate for myself to not have a C-section, like my second repeat C-section. And the knowledge that I have now, I wish that I had done that. Because, my OB said, she said to me, literally, in caveman days, you would have died. That's what she said to me. And so I was like, okay, well, if you're telling me that I can't deliver naturally ever, then I'm just going to listen to you because you are the one with the degree, right? But I wish that I knew what I know now so I could have advocated for myself and experience a vaginal birth. But either way, I have four children and they're here and they're healthy. And that is what matters. Um, Thank you, Dr. Evans. Okay, so the next question was, what lies do we need to unlearn about respectability, motherhood, and wellness in order to truly liberate Black birthing people?
Um, I always say that one of the most pervasive tenets of white supremacy is decorum. It's this idea that you always have to behave a very certain way in order to be worthy of being listened to and of having respect. And what I think we all know as Black women here is that when we are real loud and real right, people don't have a choice but to listen and to pay attention. And even if they're only listening to shut us down, they heard us. They heard what we said. And we have to stop thinking that just because someone is a medical professional, that
I'm
they are
sorry.
the expert. I'm sorry.
I'm sorry to interrupt you. I just want to say goodbye to you ladies. I am on a flight from Chicago that was delayed by like 17 billion hours. So now, finally, after being here a whole work shift, they've closed that door. They're going to start the whole process and we're going to taxi and take off. But I have really enjoyed this time with y'all on this panel. This was amazing. It's a great way to kick off this week. And thank you so much for the work that y'all do. Y'all are actual, real, live heroes. I'll be sending you your capes first, overnight soon. I'm gonna get the address from Camilla.
Thank
So
you
happy,
always for
yes,
showing up for us.
Safe
Showing up for
travel.
me. You're
happy
amazing.
Black Maternal Health Week, and much love to you all.
Thank you.
Safe flight.
Okay, bye bye.
Go ahead, Kyra. Sorry.
I was saying we have to like unlearn that just because somebody is a professional in a field that they are well intentioned. They may have more information about something than you have, but they may not be well intentioned. They may actually be using their position of having that increased knowledge against you. And it's okay to push back. It's okay to ask questions. It's okay to one of the things I do with my clients is like I don't do birth plans, I do birth preferences. And so we talk about all of the things that could happen, that they want to happen, that are important to them, and all of that. And one of the things I always tell them is ask questions. Your voice matters, your understanding matters, your consent matters, and it doesn't matter who you're speaking with. It always matters. What you need and what you want and what makes you feel safe and whole matters. And we learn at a very young age as Black women to pipe down, to be small, to step back, to stand down. Like Dr. Evans, I'm just over here like grinning, just thinking about this story that you're saying, because too often we're told don't be that, right? We're told to just, blend in, stand back. So really unlearning that our voices don't matter and that decorum matters, because y'all seen white women yell in every which way, in every which venue, at anybody at any time. And we have to not be afraid.
That's really true. Um, it's such a shame too, right? Because we're always seen as being aggressive or just angry. And I feel like that applies to all aspects of our life. I remember specifically one time, my second child had kept getting RSV as a baby, and the doctors just kept pushing it off, and they were like, "Oh, just give him a nebulizer." And I remember my sister-in-law called and she was like, "You need to yell in the emergency room." She was like, "Cause a scene, be loud, and tell them that they need to keep your baby. Like you can't keep coming to the hospital." And she was like, "I don't care if you act a fool, just act a fool." I could not do that myself, but it's true though, right? Because we don't get listened to, and still we start screaming. So. Um, it's true. Kyra, I wanted to segue with this question. Can you discuss the emotional and psychological benefits of having a doula, especially for Black mothers, and why it's so important for Black women to have this kind of support?
Yes, so I will preface this by saying, even though I am a doula, for my first baby, it was COVID. Y'all know that was a crazy time. But my second one, I had two doulas, right? Even as a doula, I needed two doulas. And so I really like to speak from the perspective of what my doulas were able to provide for me. One of my doulas was very soft and very affirming. and she supported me in whatever way felt like love, right? That felt spiritually affirming, that felt emotionally affirming. And then I had another doula who stayed on my butt that, what are you doing? What are you eating? What are you drinking? What are you, this, because I needed both of those things, right? I needed someone to take care of the little girl in me because I never got to be a little girl, right? So I needed somebody that could take care of the little girl in me. And then I also needed someone that could stand up to the grown woman in me, right? And that is the great thing about a doula, is that there are so many different types of doulas that can provide so many different layers of support. So of course you get the education and you get the advocacy and you get the physical support, the hip squeezes, because a hip squeeze is very few things like one. Okay, a really well placed hip squeeze is amazing. So not only do you get that, but you get all of those other little pieces that you maybe need to have filled in. My partner is he does not like being in hospitals, and for reasons outside of our control. We had both of our children in the hospital, and I knew after my first birth that I had to have doulas that could support me and could support him, and they did. Right, while they were taking care of me, while one was taking care of me, the other one's checking in on him, and then they would switch off. And this is happening without a conversation, right? This is happening because these are people who listened to me and who knew what was important to me, that knew what would make this feel like a great experience. And I tell people all the time that even though I had my second child in the hospital, it felt like a home birth because I got everything that I wanted. Like I caught my own baby, like everything that I wanted. But that took a lot of preparation, and I learned about that preparation as a doula. But that is something that doulas also impart to people, is how to be prepared, how to understand the physiological changes that your body is going through in pregnancy and in labor, because that pain of labor is actually a lot more tolerable when you understand exactly what's happening and why that's happening to your body. Um, and doulas can provide all of that. We're not medical professionals, but we are trained birth professionals. Like, we know what we're doing in that space, and we are there as a part of the care team.
Mhm.
I
And
don't know where this baby came from.
um, and then my next question is, this is not one that we already have, but Dr. Evans and Tiffany, are you guys seeing the rise of like doulas in the hospitals at this point? I know that doulas are on the rise right now. We're hoping in New Hampshire to be able to try to establish a doula connection too, to be in hospitals. And you're hearing about it all over the place. So are you guys seeing a rise?
Yeah, we are, and in fact, Mass Health here in Massachusetts reimburses doulas. So we're starting to see a lot more doulas. We're seeing a lot more doula companies, um, doulas actually within the hospital. Um, I think where it's a little tough is that, I mean, a lot of providers don't want to hear what a doula has to say, right? They want to be able to do what they have to do the work, get the patient delivered and move on to the next one. And I feel like that's probably like the toughest part, like the integration of doula into the care team, right? We know for a long time, they weren't considered a part of the care team. And in fact, if you wanted to bring a doula, they would be like, this is your one support person, or you can't have another support person because the doula is the person, is it. And a lot of hospitals are changing policies to consider them a part of the team. Um, I feel like there's kind of like a undercurrents like throughout the country where they are people are trying to I guess control how doulas practice. And there's somewhat of an uprising that's slowly stirring. So, yeah, the people want to medicalize it, but you're starting to see more and more people like access doulas, want doulas in the room, doulas being considered part of the care team, and doulas being reimbursed, although not reimbursement is not enough. What Mass is only offering 1,700. It's not enough by far, like the work that doulas do throughout pregnancy, during the whole laboring process, and even into postpartum. But it's a start. So
Yeah, I would say that I am seeing more doulas in the labor and delivery suite, and I totally agree with you. It used to be like, I guess during COVID times, like this is one out of two people, um, and I think now it's becoming more of a thing. But I just have to agree with you, Tiffany. The whole thing that you just said, it's like when you're on the floor and there's some docs that are like, oh, there's like a really nice doula in there. She's been really helpful with the patient. And then there's some that are like, she's asking so many questions. She so doesn't know what the heck we're doing here. She's intervening when she has no medical way to do that. And so there's like still this split between providers of accepting them as a part of the care team and really engaging them in like questions, decision making, and explanations of the reason why we're doing any interventions at all. I would say it's half in terms of the perception and the acceptance of doulas on the care team. And so it's going to take a lot. Same thing with birth plans and birth preferences. Half of the people are here for it and half people really are not. And so it's just like a luck of a draw of who is going to be on staff with you. It's really unfortunate because to me, that's like the best, like we all know what we want here. Like let's make it. Anyways, I'm not going to specifically talk about that, but I think yes, there's an increase, meaning there's more pushback from certain providers.
I popped into the chat it's actually my first little published piece, right? But that I did with the Missouri Hospital Association, specifically the Perinatal Quality Collaborative, about integrating doulas into the healthcare team. And it is written by all doulas. Everyone who participated in that was a doula very intentionally. We have a really good PQC in Missouri, considering the insane landscape here. And one of the things that we could not get in there was just a phrase that if your provider is anti-doula, then you need another provider. If you have a provider that is afraid of you having additional support and the fact that that support might push back against, the standardization and the medicalization of birth, then you need another provider. That is very, very telling. And that is coming from someone who I am, for a lot of providers, I'm on their list of recommendations. I love to work in tandem with providers. It is far too simple to say, well, everybody's just, Black women need to have their babies at home. And no, we need to have risk appropriate care. And so that requires, as a doula, being able to function in a home birth, in a birth center, on the side of the highway if I have to, in the hospital, wherever, my clients want to birth. It is up to me to be able um, to integrate into that space, but also that comes from providers wanting to integrate doulas into the maternal care field, because there is a super surgence of doulas. And I don't know who just said about them trying to alter the way that we are able to practice. That has happened in some states, like in Ohio, that has happened where there's this whole new set of regulations for doulas and what training you need to be qualified as a doula. And one of the things I'm really proud about in Missouri is that we pushed and pushed and pushed until they had included some culturally affirming, culturally reflective doula trainings in the doula trainings that are accepted for Medicaid reimbursement. We would not agree to the rules until they had that in there. We would not agree to the rules until they decided to allow there to be a board of birth workers that make these decisions about what allowed a doula to become credentialed in order to receive Medicaid reimbursement, instead of, because at one point they wanted it to be like the nursing board. Please no. Please no. And so I hope that if wherever you guys are, if your doulas need help with pushing back, send them to Missouri, which is crazy, right? Because there's a lot of crazy stuff going on in Missouri. But the doulas, in the hospital association, we on the same page. In Medicaid, we're on the same page because Medicaid actually took the administrative route. The legislation didn't even pass. Medicaid said we're still going to do this for our birthing people. And so send them to like Illinois doulas, to Missouri doulas. We're always like willing and ready to help doulas in other places push back and maintain their autonomy and being in the best position that they can be to serve their clients, because these people need us. Like the Black maternal mortality rate is not going down. We are losing programming that socializes young people to the medical field to make them believe that they can go and be doctors. So in the meantime, in between time, doulas are not the solution. We cannot doula our way out of this, but doulas do desire to be able to practice and to maintain their autonomy.
Sorry, I was muted. Thank you. I want to thank you all. I know that we have just a couple minutes left. As we're closing, if you guys could give Black women one advice, like one piece of advice while navigating the healthcare system or during pregnancy or childbirth, what would it be? And quickly, how can organizations and individuals work together to ensure that Black maternal health is not just a week-long conversation?
I can start. When I think about this question, it brings me back to when I was going through that situation with my son. And I guess what I would say, or a piece of advice, would tell them that they're not alone and that they're not imagining it, and that their instincts are real and their fears are valid. Um, I would let them know that they're the experts of their own body and their baby. Um, and sorry, and to build a circle around them, whether that be doulas, friends, sisters, aunts, people who will advocate with you and for you. I remember when I had my son, my best friend ended up coming with me to the hospital because we needed that advocate, we needed that person there because we were all walking into something we did not know what it was going to be. And she was so supportive. And she told me before we walked in, she's like, Khadijah, they're about to be sick of me. And I said, okay, do what you got to do. You know what I mean? So, but we got through it. So it's just really important that you have that support system in place to help you get through, that experience. It's, one of my pregnancies ended in a tragedy, but we got another baby out of it a couple months later. And we were grateful for that. But it's supposed to be a beautiful thing. Child's birth is supposed to be a beautiful thing. And having those people next to you that support you is going to help you get through it.
Yeah, I want to piggyback off of what Khadijah just said. You're not alone. You don't have to do this by yourself. Find your peoples, whether that's your mama, your daddy, your auntie, your uncle, your partner, your bestie, a community advocate, someone trusted in the community, doulas, midwives. Find your people and believe that you deserve care that uplifts you and uplifts your family, and trust your power and rest when you need to. We don't always have to be strong. I know we have that trope, the strong Black woman, like we can rest. Joy is resistance. I am a strong believer in mutual aid. We have to build these systems ourselves. We have to do it ourselves. We can't wait for others to do it for us. And also creating birth centers in our community. Training up people to like be doulas, be midwives. These are honorable professions. We need more of these people in our community to take care of our moms and our babies and our dads. Yeah, so I think those are the things I would suggest.
I would suggest, as the other ladies have said, like, don't go it alone. Like, don't, absolutely, you're not alone, but from the beginning, choose to go into this supported and choose to go into it educated. There are a lot of culturally responsive childbirth education classes out here, and I would encourage folks to take those before they even get pregnant. I always tell my clients, plan your pregnancy and birth the same way you would plan a wedding. You can ask someone who is like a year out from their wedding, oh, have you thought about caterers? And they will list off 40 caterers in the area. But it comes to the birth, and it's like, oh, well, I'm just gonna, My doctor is the same doctor that delivered me. And so, um, to go in informed, and supported and to take it serious because it really is a serious thing.
Mhm.
Even if we were in a completely safe time, you still gotta get a baby up out your body. Okay. That's still real serious.
I echo everyone's statements. I love that statement, joy is resistance. Like, mind blown, love that. Um, I think my statement is I've been really harsh on, or I've been really critical about the statement of you need to advocate for yourself when we never tell the providers to advocate for the patient. And so I think for me and my colleague and my colleagues, I really want to push us to advocate for our patients. It's not their job. But then when I think about that statement, I think, well, actually, a lot of white women are advocating for themselves every 5 seconds of the day. And so they are not only emboldened, but it's like, it's almost like it is a part of the deal. And so for you, as Black women that are going to become pregnant, starting to practice that in any medical encounter that you have, asking about questions, the risks, the benefits, the alternatives, those three things right there, and explaining them fully and having somebody there to record it for you or write it down, because a lot of things kind of you forget about those details until you come back and you start to really discuss this with your people that you care about and your family and friends. So not forgetting as in like actually record, not like putting a camera up into someone's doctors, but like in their face, but remembering the conversation that you had, writing it down, talking with your family, and then asking specifically in those conversations about the alternatives that they are offering and options and the treatment and whatever intervention that they're offering to you. Because that is where you get to decide what you actually feel comfortable with. And I think when people are able to make decisions for themselves, then it actually care moves forward instead of us feeling like we're against each other. Um, and so that would be my first thing. And then kind of how everybody said to bring somebody in the room with you. I think that's really important, especially because some providers, and I hear this all the time, where they'll just go into a patient room and they'll come out and inadvertently be like, this patient was so sweet. You're going to love her so much. Like, she's so good. And then they'll go into her medical history. And even those like one or two statements before they start going into their presentation really changes the outlook of how that person is going to go and treat them. But even if you have a bad encounter, sometimes that you feel attacked. And so if you have somebody there to be like, I am the person that you can also talk to, like this needs to be a group decision, especially if it's something that's pretty heated. Without that endorsement that this person's really sweet to work with, which is like clearly just like some really nice tame white girl, like, it makes it really hard to move care forward if there becomes an issue. And so if you are by yourself and you have this person that already perceives you at a certain way, it's hard to advocate for yourself. So if you have somebody else there with you that is also willing to advocate, they can't necessarily bully you into a corner. And I've seen it happen too much, where patients just end up giving in because they don't know what else to do because of a perception about them. Now, it may be the first time ever meeting the patient, actually. And so if you have somebody there with you, it's a kind of like really stand up for this is not just like a me problem. This isn't my attitude problem. This is a decision that needs to be made. It really helps people advocate for themselves. But I hate that we are always focused on the patient advocating for themselves. Like, I think that within itself is a big issue, but it's because there's a disparity between who is actually advocating for themselves, or what is expected for that doctor visit. And so the more we practice that, the more we're able to get through these things pretty quickly so we can move on with our lives. And so it's not such a battle all the time. So yeah.
Well, thank you guys all. Y'all are just magic in general. This was amazing. I feel like we're gonna have to double back at some point because this was just pure magic, just gems across. Um, we're 5 minutes late, but Black people love to talk, and I love to say that, so it is fine. Um, Thank you everyone for coming. I think that we have all of your socials on social media. So if people want to find y'all, they can find y'all on BLMNH, on Instagram, on Facebook. As always, you can always donate to Black Lives Matter New Hampshire. We love your coins, and all of your money that you give to us goes back into the community. And we hope to be offering doula services in the future too. So we are not letting our foot off the gas with maternal health things. So thank you all for coming. This was amazing, and happy Black Maternal Health Week. And we're going to go ahead and end. Thank you so much, all.
Thank you.
Thank you.